Hello all, welcome to Dental Notes and Mnemonics. Today we will be discussing about anterior crossbite, which is a common dental malocclusion. We'll cover its diagnosis, causes and management. Options, providing you with a clear understanding of this condition and how it is treated. According to contemporary orthodontics book by Sir Prophet, anterior crossbite is a condition in which one or more maxillary incisors are positioned lingually, that means towards the tongue, to the mandibular incisors. Etiology of anterior crossbite can be dental, functional, and the skeletal. And based upon these classifications or categories, we can classify anterior crossbite on the basis of etiology. In the dental type, the crossbite arises due to abnormal position or eruption path of individual teeth, while the underlying jaw relationship remains normal. It is usually seen in cases with retained primary teeth crowding or ectopic eruption of maxillary incisors. The functional anterior crossbite is caused by occlusal interferences that forces the mandible to shift forward during closure. Though it mimics skeletal class 3, the jaw bases are usually normal and the crossbite can be reversed by guiding the mandible into centric relation. Functional class 3 is also known as pseudo class 3 malocclusion. It is typically seen in early mixed dentition and should be treated early to prevent skeletal adaptation. We come to skeletal anterior crossbite, which is related to jaw bone growth. When the upper jaw does not grow enough or lower jaw grows too much, the teeth becomes misaligned. The class 3 skeletal pattern often runs in families. In children with repaired cleft lip or palate, the scar tissue can restrict the forward growth of maxilla. Some syndromes like cleidocranial dysplasia or hormonal disorders such as acromegaly can also exaggerate mandibular growth. Lastly, the trauma or jaw fractures during growth years may cause skeletal asymmetries and anterior crossbite. We may also classify anterior crossbite as a single tooth crossbite or segmental crossbite. While in case of single tooth crossbite, only one tooth is involved, usually it is maxillary incisor. The causes are usually the localized issues. On the other hand, segmental crossbite involves more than one tooth, usually a group or a segment of upper incisors, and it is due to the skeletal or arch size issues. For diagnosis of anterior crossbite begins with history taking, asking the child or the parent about trauma, habits, familial traits like prominent lower jaw, and the patient willingness for the treatment. Next, in the clinical examination, we check how the teeth bite together, looking at the incisor position, whether the mandible shifts forward, or noting any jaw discrepancies. Radiographs like lateral cephalogram help visualize the jaw alignment, while study models, either traditional or digital one, help in detailed planning and the documentation. Important to find and treat anterior crossbite early, especially in cases like pseudo class 3. If not treated on time, the lower jaw keeps shifting forward while closing the mouth, which can later cause a serious jaw problem called skeletal class 3. That's why as soon as you see an anterior crossbite, it should be treated immediately, don't wait. Compare dental and the skeletal crossbite. The dental anterior crossbite is caused by malalignment of teeth, not by the problems in the jaw bones. It usually affects one or few teeth and happens when the upper teeth are tilted backward or the lower teeth are tilted forward. The jaw size and position are normal and the face looks normal. In contrast, skeletal crossbite is due to underlying jaw problem such as small upper jaw or the large lower jaw. It often affects many teeth and facial profile may show a flat mid face or prominent lower jaw. In these cases, the teeth may tilt to compensate for the skeletal discrepancy, which means that teeth compensates the skeletal discrepancy. In class 3, the lower teeth are retroclined and the upper teeth are proclined in order to achieve overjet or overbite. Also, the reverse overjet can be seen in class 3 cases where the lower teeth are in front of the upper teeth. Increasing reverse overjet leads to more complications in the case. Functional anterior crossbite or pseudo class 3 is classified by checking if the lower jaw shifts forward when the patient closes their mouth. This shift is usually due to premature contact between the front teeth, which forces the mandible to move forward. Clinically, it looks like lower teeth are ahead of upper one. To confirm it's functional or not the skeletal, the dentist gently guides the jaw in centric relation. If the crossbite disappears and the molars are lying in class 1, it is a functional crossbite. Other signs include midline corrections during retrusion and normal jaw size on x-rays. Early diagnosis is important to prevent problems from becoming skeletal as the child grows. Correction of anterior crossbite is essential, especially between the ages 6 and 10 when the permanent incisors are erupting. Why intervene early? Because anterior crossbite rarely self-corrects and may persist into permanent dentition. Delaying treatment often means greater complexity and functional issues like mandibular shift can worsen also. Early action not only protects developing structure but also improve facial aesthetics and lip posture. If anterior crossbite is left untreated, multiple complications may arise. The most common is tooth wear or atresion followed by mobility of lower incisors due to their labial positioning. More seriously, it may lead to gingival recession, alveolar bone loss, and even disturbances in jaw growth. A continuously protruded condyle may stimulate further mandibular growth, worsening the skeletal imbalance. Consideration before the early intervention of anterior crossbite is that first, the child's oral hygiene must be good. Then the severity of skeletal discrepancy should be evaluated. If it's too severe, interceptive treatment might not be enough. We also check for dentoalveolar compensations like tipped incisors and amount of overbite, which can affect treatment planning. Importantly, the child's compliance and general health status must also support the planned intervention. Let's quickly learn what are the dental compensations. In anterior crossbite, when there is skeletal discrepancy like small maxilla or large mandible, the teeth often adapt by changing their position. The upper teeth may tilt forward, which is known as proclination, or the lower teeth may tilt backwards or retrocline to create a temporary bite contact. While this helps masking the underlying jaw imbalances, it complicates surgical treatment. During orthodontic surgery planning, these compensations must be reversed through pre-surgical orthodontic decompensation. This means the teeth are moved back to their natural positions even if the bite worsens temporarily. Only then can a surgeon accurately correct the jaw positions, enabling stable and harmonious results after surgery. The management of anterior crossbite follows 4 phases. First is preventive, interceptive, corrective, and finally surgical. In the preventive phase seen during the primary dentition, the focus is on eliminating habits, maintaining space, and guiding eruption to prevent crossbite formation. In early mixed dentition stage around 6 to 9 years of age, interceptive treatment of dental anterior crossbite is highly effective, as the issue lies in tooth position rather than jaw structure. Simple methods like tongue blade therapy or extracting retained deciduous teeth can help in mild cases. For more active correction, an upper removable appliance with springs or screws can gently move teeth into position, especially in cooperative patients. A lower inclined plane helps guide the lower incisors back by altering the bite path and can be removable or fixed. Cemented bite pads on the lower molar can use to separate the bite and allow upper teeth to move forward. In cases involving multiple teeth or root correction, fixed braces are preferred. Early management ensures proper bite development and prevent skeletal problems in the near future. Corrective phase typically during the late mixed or the permanent dentition. Established crossbite are treated using fixed orthodontic appliances, cross elastics, or functional appliances. Finally, the surgical phase is reserved for the adults with skeletal discrepancy, where the orthognathic surgery combined with orthodontic treatment is required for full correction. Let's go over the key treatment modalities used for managing skeletal anterior crossbite in growing patients. These are mainly orthopedic and orthodontic interventions aimed at modifying jaw growth. First of all is the protraction mask, which is the appliance uses external traction to pull the maxilla forward. It is especially effective when started during early mixed dentition phase, typically between 6 to 9 years of age, when the sutures are still responsive to orthopedic forces. The chin cup applies upward or backward pressure on the mandible, thereby restricting its forward growth. This appliance is best suited for growing children, and it is often used when mandibular prognathism is a concern. Class 3 elastics with a skeletal anchorage involves the use of mini implants or mini screws or plates placed in the bone to which plastic elastics are attached. The force generated help in repositioning maxilla and mandible. This method is effective in older children or adolescent where the conventional orthopedic effects are limited. Functional appliances may also used to stimulate forward growth of maxilla and simultaneously restrain mandibular development. Tandem traction bow appliance is a combination of intraoral splints connected with traction bows to deliver orthopedic forces. It is especially effective in managing severe skeletal class 3 in early to mid mixed dentition. These all appliances are most beneficial before the skeletal maturity and should be selected based on patient's age, growth status, and severity of skeletal discrepancy. Reverse twin block is a removable functional appliance which is opposite to the conventional twin block. It inclines are reversed to posture the maxilla forward and mandibular backward, encouraging proper jaw growth. Now let's discuss the role of orthodontics in surgical planning for skeletal anterior crossbite cases. In case where the skeletal problem is mild, orthopedic correction with growth modification appliances like face mask or chin cups may be sufficient. In such cases, surgery is often not required, especially if caught early during the growth. Borderline surgical cases are those cases where the discrepancy is borderline, meaning that it is not clearly surgical but also not fully manageable with appliances alone. Class 3 elastics or skeletal anchorage devices can be used to delay or even avoid surgery. However, these cases need close monitoring of growth pattern over time to decide the final approach. In adult patients or those with a severe skeletal discrepancy, orthopedic appliances have limited effect. In such cases, orthognathic surgery becomes essential. The commonly used surgical procedures include Lifford 1 osteotomy for maxillary advancement, bilateral sagittal split osteotomy for mandibular setback. So after the surgery, orthodontic treatment continues to fine-tune the occlusion. The goal here is to align the teeth and ensure proper coordination of arches for stable bite and good aesthetics. Let's compare the dental compensation and the surgical planning in the management of anterior crossbite. Dental compensation is typically used when crossbite is mild or moderate. This method corrects the problem by adjusting the position of the teeth, either by proclining the upper front teeth or retroclining the lower ones. It is mainly suitable when the skeletal base is normal and the problem is dentally in origin. On the other hand, surgical planning is indicated in moderate to severe cases, especially when there is skeletal discrepancy like prognathic mandible or retrognathic maxilla. Here the issue cannot be corrected just by moving the teeth, so we have to go procedures like Clifford 1 osteotomy or mandibular setback surgery. In dental compensation, we use orthodontic appliances such as removable plates or fixed braces, and this approach is more common in growing patients. Surgical correction is usually reserved for adults once growth is completed, and it brings significant changes to facial profile. Although it is more invasive, the results are more stable, and especially in cases with a strong skeletal component. Management of functional anterior crossbite includes early correction by eliminating occlusal interferences through selective grinding or using appliances like tongue blade, removable blade planes, or Z springs. Early intervention prevents the development of permanent skeletal class 3 pattern. Thank you for watching this video. Early detection and proper management can make all the difference in child's smile and facial development in case of anterior crossbite. If you found this video helpful, don't forget to like, share and subscribe for more videos like this. See you in the next video. Till then, bye bye. Take care. Have a nice day.